Our next speaker is Professor Carsten Flohr. He is head of the Unit for Population-Based Dermatology Research at St. John's Institute of Dermatology, and he's going to talk to us about, is there still a place for conventional systemic eczema treatment in the biologics era? Thanks, Carsten.
Thank you for the introduction, Jane, and thank you for the invitation. Can I have my first slide, please? Just briefly, my conflicts of interest. I'm the chief investigator of the treatment of severe atopic eczema in children trial. I also lead the UK-Irish Atopic Eczema Systemic Therapy Register, A*, and I'm a principal investigator of the International Treat Registry Task Force. All three studies will come up as part of my talk. And I'm also an investigator on the EU Horizon 2020 Biomap project, which is led by Catherine Smith and Stefan Weidinger from Kiel. Andrew has said it, and others in the audience, we live in very exciting times with so many new therapies coming through. But I'd like to ask, are we potentially getting excited too early? So as part of my talk, I will briefly review the current armamentarium, the conventional novel therapies that we've got available. I'll talk about the key factors that influence clinicians' decision-making. What do we know about these factors already, and where do we need additional study evidence? All in the quest to answer this question, is there still a place for conventional systemic eczema treatment in the biologics era? Thanks to our now intricate understanding of what happens in eczematous skin, we've got loads of new targets. There is the beating heart of eczema inflammation, the Th2 pathway, but not just that. We've got TSLP, for instance. We've got IL-22, 23, we've got IgE and IL-31, and monoclonal antibodies being tested against all of these targets. And then we've got the selective JAK inhibitors too. And compared to those exciting therapies, the conventional treatments really seem like stale ale. But what's their place now and in years to come? You know the key players well from your own practice. They have been in clinical practice for years: azathioprine, cyclosporin, methotrexate, and mycophenolate mofetil. Azathioprine inhibits purine synthesis and leads to leukocyte proliferation reduction. Cyclosporin inhibits T-cell-dependent immune responses. Methotrexate shows a reduction in allergen-specific T-cell activity, but how it really works in atopic eczema is not clear. And mycophenolate, like azathioprine, leads to leukocyte proliferation reduction. Azathioprine works slowly, but when it works, at least anecdotally, it seems to have the potential to switch off the eczematous inflammation in the long term, changing natural history, although there's currently no RCT to prove this. Cyclosporin works fast, but when you stop it, it very often rebounds from an eczema point of view. Methotrexate, like azathioprine, takes time to work, and again, like azathioprine, anecdotally, can turn the eczematous inflammation around in the long term, even off therapy. But again, we are lacking RCT evidence from that point of view. And then there is no RCT evidence for mycophenolate mofetil currently in the public domain. The only conventional systemic therapy that is currently licensed is cyclosporin, and only in adults. And clearly there are concerns about the safety signals of all of these drugs: cyclosporin, renal function impairment, for instance, azathioprine, cancer risk. But what we know about the safety profile in the long term about these treatments comes from GI and rheumatology cohorts, not from atopic eczema ones. A couple of years ago, the International Eczema Council asked the important question, when to start systemic therapy in atopic eczema. We came up with this algorithm, and that's great. But once you've come to that decision that you want to start someone on a systemic agent, which drug are you actually going to choose? So we currently have got no gold standard systemic therapy, even not for the conventional ones. What are the key factors that influence clinical decision-making in clinic? Well, short-term efficacy is important, but what about the long-term effectiveness picture? What about long-term, especially severe adverse events? Impact on quality of life? Tolerability? The patient will want to know about. How good do these treatments impact on itch and sleep? What about the route of administration, whether you give something under the skin with a needle or whether you have an oral treatment might matter in particular to patients? Children hate needles, so they might prefer an oral treatment just for that reason. And then the intensity of monitoring test comes into this clinical decision-making as well. And probably most importantly, cost effectiveness. And NICE clearly has got something to say and will interfere, if you like, in our clinical decision-making. And I'll come back to the NICE decision on dupilumab later as part of my talk. So all of these factors need weighing up. And it's not just us as clinicians, of course, but also working with our patients to think, what in balance is the best treatment for this particular patient we've got in front of us? I'm now going to show you some original data that we recently published in F1000 Research. There are currently 26 randomized controlled trials published. 14 of those are on novel systemic therapy. A third are head-to-head trials, but they're only head-to-head trials for the conventional therapies. All novel systemic therapies have been compared to placebo thus far. And there's a bit of a Tower of Babel situation when it comes to the primary endpoints in these trials. The beloved child of the IGA, from an FDA point of view, features quite strongly, but people have used different iterations of the IGA in different trials. 3 trials have used the SUSAT. Other trials have used the score at 50, for instance, and 3 trials. 7 trials looked at change from baseline in the score. And then you've got different iterations of the EASI as well as primary outcomes, EASI 75, 50, or change from baseline. And these trials have been done over different time periods. This is a rather busy slide, but I'll talk you through it step by step. It's the short-term picture for the EASI in the different trials, conventional and novel systemics. And each trial is in a different color, and where possible, we have combined the results from several trials, for instance, for dupilumab. And to help you orientate yourself and to compare the effect of these treatments against placebo, we have calculated the mean placebo response across all of these trials, indicated by the red dotted line. And to make it even easier for yourself to orientate yourself around this figure, I've labeled the different graphs here. So baricitinib and dupilumab do very well. Andrew has already said, dupilumab works very quickly. You see a response early. Whereas azathioprine and methotrexate don't work so well. In fact, they're not better than placebo early on, but from clinical experience, we wouldn't really expect that anyway. They take time to work. Cyclosporin close on the heels of baricitinib and dupilumab. The long-term picture, so this is EASI score, percent change from baseline up to 64 weeks, is a bit different. Nimolizumab does well. It gets there down to about 80% reduction in EASI from baseline, but it takes a very long time to get there, whereas dupilumab already reaches that point after about 20 weeks. Methotrexate and cyclosporin don't do badly, but we don't have any data beyond 20 weeks for these 2 drugs. And ustekinumab is hardly better than placebo. In fact, there was no statistically different result there compared to placebo. Looking at the score, it's a slightly different picture. Here, cyclosporin, interestingly, is at least as good as dupilumab, and that's because the trial that used SCORAD as an outcome used a higher dose, the 5 milligram per kilogram per day dose of cyclosporin. The long-term picture using the SCORAD, very similar to what we saw with the EASI. So in summary, when it comes to treatment efficacy, using these indirect comparisons, methotrexate and azathioprine seem inferior to dupilumab, baricitinib, and cyclosporin in the short term, but the more long-term picture suggests that methotrexate performs at least as well, if not better, than some of the novel systemic agents. And no study has so far assessed the potential induction of disease remission, so following people up in a clinical trial of therapy, and there's no comparative cost-effectiveness analysis available either. And just to lament this fact again, that we are currently lacking a gold standard conventional treatment to serve as a benchmark against every other treatment that's coming through. That gap, at least for children, hopefully will be closed by the UK-Irish treatment of severe atopic eczema in children trial. We've now finished recruitment of children aged 2 to 16 who were all systemic treatment naive. We randomized them to methotrexate and cyclosporin, gave them treatment for 9 months, and then have followed them up for 6 months of therapy to see whether methotrexate is better compared to cyclosporin in terms of remission induction. A second primary outcome is treatment response at 12 weeks, and we are hypothesizing that cyclosporin might be better at that compared to methotrexate. Apart from treatment effectiveness, we're looking at the safety profile of both drugs, the impact on quality of life, and we're also doing a comprehensive cost-effectiveness analysis. And in addition to that, mechanistic work to try and understand how methotrexate switches off the cutaneous inflammation using immunology and metabolomics tools. While you've been listening to me, you've probably been thinking, well, this is really not the way to compare these treatments. They're indirect comparisons. It's like comparing apples with pears, and even the pears are not alike. And that's true. There are differences in study populations, age, sex, ethnic group, baseline disease severity, just name a few. The study designs are different. The drug doses, we talked about cyclosporin trials using quite a range of doses. Some trials have allowed topical corticosteroid use, others didn't. The severity outcomes are different, the follow-up points and the length of follow-up, and the list continues. And it spills over into patient-reported symptoms as well. Luckily, for severity, we only have the poem in these trials, but for pruritus, 5 different scales alone, for sleep 3, and psychological measures 2. So the Tower of Babel situation continues even there. For quality of life measures, the situation is even worse. And I'd just like to highlight that the health technology agencies really like to see the EQ5D as a quality of life measure because that allows the cost effectiveness analysis that will be so important in the decision making for agencies like NICE. In the interest of time, I'm not going to show you the quality of life impact data from these different trials, but the story is very similar to what I've told you about treatment effectiveness. So what we need are head-to-head trials, not just pitching the conventional treatments against each other, but conventional against novel. This is the trial that Catherine and Andrew and others are working up. It's very important to do these sort of studies, as well as comparing the novel treatments against each other. And it's really heartening to see that quite a few pharmaceutical companies are moving in this direction in an ever more competitive field. But I hasten to add that head-to-head trials are likely to always be small in number. So where do we go from here, apart from having more head-to-head trials? A couple of years ago, Phyllis Spools from Amsterdam and myself, with colleagues from across Europe and the US, also including 2 patients, Bernd Ahrens from the Netherlands and Amanda Roberts from the UK, founded the Treatment of Atopic Eczema Registry Task Force. And this is in the recognition that we will always have a lack of head-to-head trials. Randomized control trials have got rigid inclusion and exclusion criteria, and actually the patients going into these trials are not necessarily representative of the patients we see in clinical practice. And then RCTs are very short-term pictures of what happens, for instance, also from a pharmacovigilance point of view, and they lack power to look at rare but potentially important side effects. So we need real-world data, the sort of data that Andrew presented on dupilumab, and long-term evidence on treatment effectiveness, impact on quality of life, safety, and cost effectiveness, comparing the new with the old. So the TREAT task force really is about standardizing data collection across countries, using the same outcomes when it comes to data collection, enhancing, therefore, comparability, and allowing data pooling where necessarily across country borders. And that's particularly important for rare, important adverse events such as malignancy, where there's a long latency period as well. And the UK-Irish A-STAR register uses the consensus from the TREAT registry task force consensus exercise to look at treatment effectiveness, safety, impact on quality of life, and cost effectiveness. And we also have a bioresource led by Nick Reynolds which will undertake some mechanistic studies to understand how these treatments work, moving towards a stratified medicine approach. We are currently in the process of opening up the first 14 sites, but we're really looking forward to work with you as the UK dermatology community from 2020 on, getting more sites in and working together on these important aims of the study. Let me come back to NICE and remind you of the NICE appraisal on dupilumab. You're probably familiar that the initial submission from Sanofi was unsuccessful. Dupilumab was not considered to be cost-effective using the NICE criteria of being under £1,000 per quality-adjusted life years. But the final decision was positive. Dupilumab is now recommended in patients who have not responded to at least one conventional systemic therapy. What changed the NICE decision? Well, the company changed their commercial arrangement, so the drug got cheaper. But I'd like to highlight, and this is directly from the NICE decision document, that it was the inclusion of longer-term data from an open-label study to inform the stopping rate in dupilumab beyond 52 weeks that was important, and also including data from even longer open-label extension studies to support the estimates of the effect in patients receiving dupilumab beyond 2 years. That really had an impact. So observational data plays a key role, and other health technology agencies in Europe are taking a similar approach. And just finally, to pitch network meta-analyses and the importance that they will have complementing the evidence from clinical trials and real-world data. For those not so familiar with network meta-analyses, an NMA allows multiple comparison of treatments in a unified analysis. It allows, and this is important, direct and indirect comparisons. So even where you don't have head-to-head trials, you can still statistically compare different treatments in the NMA. Pooling estimates can also provide greater statistical power. And Aaron Drucker from Canada and I are leading on a systematic review and network meta-analysis on the systemic immunomodulatory treatments, so the novel and the old treatments for atopic dermatitis. This is the protocol, but we're hoping to publish this over the next few months, so watch that space. So in summary, we've still got quite a way to go. Yes, we need more conventional systemic trials. We need more novel therapy treatment trials. We need head-to-head trials, of course, and the network meta-analyses will be important to fill some of the gaps in our knowledge. We certainly need treatment registries, not just in one country, but in others too, partly because the treatments that are being chosen in different countries, for instance, comparing Germany with the UK, are different. Germany has got a very large cohort of dupilumab patients. They're allowed to give dupilumab as first line. We will probably never be in that situation in the UK, and therefore we'll have very interesting contrasts and differences. Again, thinking about pooling data will be important. I'd just like to pitch stratification in any of these studies, trying to understand which patients respond better to which treatment, all in the quest towards personalized medicine. So just to answer the question of the talk, despite the exciting novel systemics coming through, the conventional treatments are here to stay, at least for the foreseeable future. Thank you very much.
Thank you, Carsten, very much indeed. Very exciting area and lots more work to be done. Are there any questions from the floor? Yes, please.
At risk of being an old man speaking, I'd just say how much I welcome seeing this, your two talks about what's happening in eczema. But after 40 years of wrestling with eczema and rather giving up systemics as too toxic in the old days, and I've never prescribed dupilumab, I don't want to end my last BAD without reminding you about habit reversal and the fact that conventionally adding habit reversal to topical steroid treatment cleared 80% of our sequence of patients, which we published from the Westminster 10 years ago now, and that they stayed clear, 75% of them, at 12 months. Their consumption of topical steroids was minimal once they'd done their cognitive behavioral therapy. And I think your placebo responses of 30% probably include this, because all the attention of the clinic and everything is one of the drives that stops people habitually scratching. And the habit of scratching is what causes lichenification. And also a lot of the inflammation that you show in your immunology is in response to trauma and friction on the outside of the skin. And I don't think we should throw away helping our patients to stop scratching. And we have to do that not just by telling them, but by some mechanism of cognitive behavioral therapy. And I think it's terribly important. And it worked at Westminster, and we got people off systemics at Westminster. So don't throw it away, is all I would say.
Definitely not. I mean, thank you for pitching that. I mean, it's hugely important what you're saying, Richard. And the adult service that we run at St. John's has got a clinical psychologist involved, intricately involved in the clinical management. We're doing the same with our severe pediatric eczema clinic patients as well. It's just that we are seeing these patients right at the end of their journey. And if the sort of intervention that you are talking about, would happen much earlier, then that would be helpful. We would probably prevent a lot of people ever ending up having to have systemic therapy. So early intervention is important. And I think there is a place for clinical trials looking at that too. For instance, with aggressive, in a positive sense, topical interventions in early life, rather than sitting back and, I mean, you will have seen so many patients yourself over the decades coming from GPs who have not adequately treated the eczema but not referred the patient early enough. And again, so there's this delay from primary care to secondary care as well at an early age that we're playing into, people then gradually evolving a more and more severe picture because of itch scratching and nobody intervening there. And as you say, the cognitive side plays a very important role there in clinical management.
Microphone 3.
Hello, it's Amanda. I'm a
hello.
patient person. I just wondered, how long is long-term follow-up and how long should it be?
Well, it should be as long as possible, Amanda. I mean, thank you very much for you working with us on the TREATS task force. We want to have patients in these registries for as long as possible, at least 5 years or so. In the context of clinical trials, long doesn't go beyond 4 months very much, and then people go into open label extension studies. But it's good to have at least pharma companies investing in people remaining on these treatments for years. So yeah, as long as possible is the answer, really.
Yeah, 4 months isn't long term, is it? Not in a lifetime. And even 5 years isn't long, I'm afraid, in a lifetime. Thank you.
Thank you. Microphone 1. Final question. Thank you.
I thought that was fascinating. I was interested to see your data on methotrexate. And with all our increased understanding of the association and the mechanisms of liver disease occurring in psoriasis, in atopic eczema, do you see as many side effects with methotrexate in long-term treatment, or do we just not have the data yet?
So I mainly see children, as you might be aware, and interestingly, in the TREAT trial, where we are very carefully monitoring children in terms of renal function, for instance, but also liver function, we haven't had a single child stopping therapy because of severe adverse events due to methotrexate. There was one child who had to be discontinued because of recurrent herpes simplex infection. But I have the impression from the limited data we have in children that these drugs are actually much better tolerated than we think. I'd have to turn to Catherine Smith and Andrew really to ask them about their experience from their severe eczema clinic in adults and whether they are seeing significant liver disease in their cohorts. Andrew, do you comment on that?
I'm happy to comment from the Royal Free experience. So methotrexate, in fact, is our first line in our clinic, and we have long-term safety profiles in many of the patients. The patients don't have a high body mass index, as many of the psoriasis patients do, so we don't see fatty livers, and I think for that reason we don't see liver toxicity.
Oh, that's interesting.
Thank you very much. I think we'll close there. Thank you to all our speakers for a very interesting and stimulating morning.